Hi, welcome to our presentation. My name is Isabel and my colleague's name is Sarah. And this is our systematic review and meta-analysis on the effect of anti-pronation shoes. So imagine you're a regular runner and you start having pain at the bottom of your foot. You decide to go shopping for some new shoes, but how do you decide what shoe to buy? Hopefully our presentation will help you out with that. So recreational has become more popular, but with running comes running-related injuries, which we'll now call RRIs. Many believe that overpronation is a risk factor for injury. And pronation, which looks like the foot arch is falling inward, is necessary for shock absorption. Peak rearfoot eversion angle is a component of pronation and is often used to determine the influence of footwear on foot motion. However, overpronation can cause excessive internal tibial rotation and strain at the hip and spine. So if runners believe that overpronation is a risk factor for RIs, then they may be inclined to buy anti-pronation shoes.
So currently there's no objective standardized subclassification for running shoes, so anti-pronation could mean motion control or stability with different shoe constructions. Motion control shoes are traditionally prescribed for people with low arched, overpronated feet, and they aim to reduce excessive pronation and rear foot motion. We define motion control shoes as having dual density ethyl vinyl acetate in the midsole. So currently there's no evidence that motion control shoes reduce RRI incidence, control rear foot eversion, and reduce pronation. And there's little evidence matching that you should match your footwear with your foot morphology.
So the purpose of our meta-analysis is to better understand how anti-pronation shoes affect RI incidence and rear foot eversion and enhance PT's clinical reasoning for shoe prescription. So that leads us to our primary question: do anti-pronation shoes affect running-related injuries and peak rear foot eversion in recreational runners? Our alternative hypothesis is that they will significantly decrease both these outcomes, and our knowledge is that they will not. So diving into the methods, our inclusion criteria include recreational runners, which were defined as running regularly, at least 60 minutes or 15K a week and not paid, comparing motion control to standard or neutral shoes, running-related injuries, which is defined as self-reported physical pain that impedes running for at least a day, looking at rear foot or ankle eversion. We're in English, primary and quantitative studies, and examining adults. Our exclusion criteria were that they looked at walking or gait, used external insoles, compared barefoot to shod, or minimalist versus maximalist.
So from each article, we took the mean, standard deviations, odd ratio, and effect size for each article and used a Q statistic to measure heterogeneity and the associated p-value, which if it was less than 0.05, we use the random effects model, and if it was greater than 0.05, we use the fixed effect model. We gathered all the effect sizes and found the grand effect size and 95% confidence interval. We plotted all those on forest plots and converted those to clinical units.
So let's go into the results. Here's our Prisma diagram. We ended up with 6 studies. Randomized controlled trials were scored with the Pedro checklist, and observational studies were scored with Strobe. We ended up with 4 studies looking at rear foot eversion and 2 looking at RIs.
So looking further into the articles about ankle and rear foot eversion, 2 of them only looked at females, whereas the other 2 looked at specifically males. They all used a multi-camera system to capture the quantity of rear foot motion, but a couple of them looked specifically at ankle eversion and they put the reflective markers on the skin, whereas the other 2 looked specifically at rear foot eversion and they put the markers on the shoe or didn't specify. We also reported the results here. And these are the articles that looked at self-reported RRI incidents. Notice that Ryan et al. Only looked at females, whereas Malisu looked at all genders. And Malisu et al. Examined the individuals for twice as long as Ryan et al. And we reported the results of how many people got injured here. So this is our forest plot for rear foot and ankle eversion. We used a random effects model since P was less than 0.05. The grand effect size and confidence interval were less than 0. So runners had reduced rear foot eversion with motion control shoes. And this is statistically significant since it's all less than 0. And if we convert it to clinical units, then on average, if you have 7.4 degrees of eversion, then you can expect a 1.6 degree less amount of rear foot eversion when you're wearing motion control shoes. And looking at running related injury incidents, we used a fixed effects model since P was greater than 0.05 and the grand effect size and confidence interval were less than 1. So that meant they had a lower risk of injury with motion control shoes. And this is statistically significant since it did not cross 1. So if someone wears motion control shoes, they're about half as likely of getting a running related injury than someone wearing neutral shoes. So based on our results, we're able to reject our null hypothesis in favor of anti-pronation shoes, reducing RI incidence and improving rear foot eversion during running. There were some differences between our studies, though. The gender of participants, the length of time that people had got to get used to the shoes, the brands of shoes that were used, where they put the markers on the shoe versus the foot, and the age of the participants, ranging from 18 to 35 or 40 through 60.
So since we found decreases in both of these outcomes, we had to wonder, are they correlated? One explanation could be that anti-pronation shoes should decrease RI since they decrease peak rearfoot eversion, if indeed peak rearfoot eversion is a risk factor for injury. Other explanations may be that they reduce the available range of motion, reduce fatigue on musculature, or decrease medial forefoot loading, which leads to less pain. Our study also had some limitations, including the restricted search to 4 databases. We only looked at recreational runners. Our studies used different shoes, which might have varying construction and midsole stiffness. And they also had short running trials on treadmill, which might not translate to longer runs over ground. So going into some clinical implications, 2 of our studies found that rear foot eversion increased due to fatigue regardless of the shoe, and that anti-pronation shoes actually decreased rear foot eversion in those fatigue conditions. So we can recommend to clinicians that they might recommend to their patients anti-pronation shoes for fatigue conditions. The question also kept coming up, should you prescribe shoes based on foot type? One of our studies said yes, and the other one said no. So we would consider prescribing anti-pronation shoes for pronators, but you shouldn't base it on that automatically. And lastly, we have to consider whether our measures of pronation are accurate, because a couple studies found that just visual analysis or looking at static measures of foot posture don't always translate to dynamic pronation. So these are the conclusions of our study. Anti-pronation shoes decrease running-related injuries and decrease peak rear foot eversion angle compared to neutral shoes and recreational runners. It varied a lot with these factors that we presented that we've covered in the last couple slides. And so clinicians may prescribe anti-pronation shoes if they believe excessive rear foot eversion causes these symptoms. So here are our slides. Thank you so much for listening. Special thanks to our faculty and peer group. If you have any questions, feel free to email us. Thanks a lot.